Welcome, everybody, to the third episode of Grand Rounds in Atopic Dermatitis. I am once again Lisa Swanson, dermatologist and pediatric dermatologist, Boise, Idaho. I'll introduce you to my other half, Douglas.
Yes, nice to be here again with you, Dr. Swanson. I'm Douglas DiRuggiero, a physician assistant in Georgia. Love taking care of patients with atopic dermatitis.
It's certainly gotten a lot more fun in the past, 7.5 years during the atopic dermatitis revolution. I've been in practice 14 years. The first 7 were tough. I mean, we didn't have as many options as we do now, and it's really a joy to treat atopic dermatitis these days. I feel very grateful to be a part of this revolution,
Yes.
Well, we'll start with this first case. This is one of my patients. So this is a 16-year-old male with a long history of rash. It's been called atopic dermatitis. It's been called psoriasis. It's most severe on his palms and soles, and he'll get occasional patches on the antecubital fossa and popliteal fossa, significant itch associated with it. And these are his clinical pictures of his hand and of his toes, of his feet. And so this is what I was trained to call psoriasis-eczema overlap, where, it kind of has features of psoriasis, it kind of has features of eczema, and you can see why the diagnosis kind of varied over the years. You look for other clues, other areas of involvement. Is it on the elbows and knees? Is it in the antecubital fossa and popliteal fossa? Are you seeing anything on the eyelid? You're looking for keratosis pilaris. You're looking for hyperlinear palms. You're looking for maybe geographic tongue to point you towards psoriasis. So you're kind of looking for these clues to help you differentiate, is this eczema or is this psoriasis? The other thing is that now we have some treatments that we can consider that are often effective for both. They're so effective that they're effective for both. And so for this teenager, I talked about topical corticosteroids. He had been on some, they were kind of wimpy. And so I did talk about more potent topical corticosteroids. I did talk about topical ruxolitinib, and that's the option we ended up choosing. I did not mention topical roflumilast because this was from before its approval. And so we ended up going with topical rux. And I also kind of planted the seed that, geez Louise, if this doesn't cut it, we might want to consider systemic therapy with either dupilumab or an oral JAK inhibitor. And so he and his mom were prepared for that if that opportunity arose. But we went ahead and started with topical ruxolitinib. What are your thoughts, Douglas? What do you think about this case?
Well, I think just to kind of focus in on what you said at the beginning, this is a great case if I have a student rotating with me or a resident rotating with me to say, look, how you get better at dermatology is you just don't look at things, you look for things. And so what the differentiator between when I did internal medicine for 3 years before I got into dermatology 25 years ago is that I used to look at a rash, run out of the room and go find my old Fitzpatrick pocket guide that had the red and black cover. You kind of date yourself based on what the color cover was and try to find a picture that matched. But in dermatology, we start looking for those things. That's an important point that you made, particularly when you think it's an overlap. Changes in the nails, anything on your groin. If you think it may be psoriasis, think about a man, anything on the head or on of the penile shaft or the head of the penis. Those areas where we could see psoriasis, family history, joint involvement. So whether you're doing that exploration, looking for things in the personal history and asking them about them through questions, or you're looking at things, this is a great case where these people need to be in gowns, right? You don't make a diagnosis of this easily, and even when they're in a gown, but it's very difficult to make a diagnosis if you're just going to look at limited areas. So this is, get in a gown. I need to see all of your skin. If you really want me to help you and get you past a point where we can do that. The other frustrating thing with these patients is the biopsy, which so often comes back as psoriasiform dermatitis. It doesn't help you much. It may have a spongiotic appearance, but it's loaded with neutrophils, which may make you think it's more psoriatic in nature. So even that's tough. So I agree with you. I mean, certainly this is a person who would benefit depending on, the impact on the quality of life, which I think would be pretty substantial with hands and feet involved, of being on a systemic medication. But sometimes we've got to get them on other things, or we are going to put them on topicals to bridge them towards getting them on the systemic or letting them make the decision and investigate that and talk to the other spouse. Is this what we want to do? And sometimes you got to buy that time and put them on a topical medicine. And the reason I agree with the topical, ruxolitinib is because we're seeing that these JAK inhibitors are working in multiple disease states, and it's got that crossover that's there. I agree that topical tacrolimus has had some benefit in inverse psoriasis and has helped, but it hasn't helped much, in my opinion, with plaque psoriasis. It may help with HANS, as we mentioned in the last episode. So, and I agree with you too. I mean, maybe this topical roflumilast that's out would be an option as well. Again, it wasn't an option when you first saw this patient. So, yeah, we're going to go through our list of good topicals, both a steroid that may benefit them to calm things down, a non-steroidal that would be good for them. Whether you view the new novel non-steroidals as first-line therapies or maintenance therapy, we can make arguments for both of those. I use them in both scenarios. But I agree that this is probably the way that I would have gone also with this patient, and certainly had them lean towards considering, let's get you on something that could give you, full systemic suppression of this disease.
Well, and I'm so glad you mentioned the biopsy thing, because during my early years of practice, I biopsied in times of doubt between eczema psoriasis overlap cases, and it was never helpful. And so I actually stopped. I don't do biopsies to differentiate the two conditions. We have so many therapies that can kind of help either way and can sometimes actually help you diagnose it depending on what works for the patient. And so I don't even bother with that anymore. I also wanted to quickly mention that, you look at the hand and the feet and you think, geez, if I was going to use a steroid, I would want to use something super potent like clobetasol. And I think that topical Rux has the efficacy and speed of improvement of not only a topical steroid, like clobetasol. And so these hands and feet just screamed topical Rux to me. Topical ruxolitinib does have a head-to-head study, just a 4-week small head-to-head study. It was in phase 2, comparing topical Rux to triamcinolone 0.1, our bread and butter. And with regards to every endpoint, the topical Rux outperformed the triamcinolone. So we know that. And with clinical use, gosh, I really equate topical Rux's potency to something along the lines of clobetasol. It's very effective.
I don't disagree with that. Let's go to the next case. This is one of my patients, 38-year-old female, widespread, patchy, flexural areas, persistent itch, did not have atopic dermatitis as a child. So this is one of those adult onsets. And, a lot of people don't outgrow it and carry it all through adulthood. And then we also see this bimodal phase. This distribution was starting somewhere in the early 50s. We begin to see an uptick in patients that come in that are being newly diagnosed with atopic dermatitis. And I see a fair number of these patients now. I don't know if it's changes. I think these numbers are on the rise over the last 2 years, 5 years, 10 years. You see a steady growing. Could be a change in demographics, where people are living, what they're doing, what's in their diet. But for whatever reason, we're seeing things that don't look like generalized elderly xerosis. Certainly not 50s wouldn't be considered elderly, but it's going beyond just your regular xerosis to having this true atopic dermatitis. The biopsy shows sponge derm, flexural areas, classic presentation, involves the face often, and that was the case for this woman here. So for me, the treatment option was systemic, at least letting them consider all of those things. She's already been on the 1-pound jar of triamcinolone with like 3 or 4 times, not wanting another one. I think we talk so much about patients wanting steroids. I'm finding more and more that patients don't, and I don't live in a real savvy, urban environment where you would think maybe the patients would be a little more feng shui and don't want that. I live in a very rural area, and even this rural area, even with people that have state insurance, I'm seeing these moms come in and say, is there anything that we can give them that's not a steroid? Anything that I can use that's not a steroid. So I think that the word is effectively getting out to the patient population that steroids have problems and they need to be used judiciously and cautiously, although they have a very important role. But for this particular patient, it was basically a presentation on, we have some great systemic medicines out there. We have injectable medications that are monoclonal antibodies. Here are the ones that are available and that are beneficial. We also have oral medications in the form of JAK inhibitors. Here they are. And just going through the differences in the two, with blood monitoring with our JAKs, not having to do any monitoring with our monoclonal antibodies, efficacy and of each of those, and then the box warnings, which we've talked about in all of our episodes, that you would want to work through, talking to them about their comorbidities, their coexisting diseases they may already have, and how to navigate that. I believe the oral JAKs in the derm space for this age group, very, very safe. But this particular patient, after going through the presentation, decided to go on to dupilumab, and we actually started it right in the office, which is nice to be able to do that. She had great private insurance. We knew we'd get it covered, and we ended up starting that medication in-house, and so. But it's nice to have these options. We've got other monoclonal antibodies out there. Don't want to, with tralokinumab, but now most recently lebrikizumab being an option for us, not an option at the time of the presentation for this patient here. But it's like you said earlier. It's so exciting to take care of atopic dermatitis right now with these patients, because I think back to stepping into derm at the end of 1999 and early 2000, and it was all cyclosporin and steroids and phototherapy. And a lot of other stuff that none of these things really had FDA approval, mycophenolate, methotrexate, all these things. And it's nothing more frustrating to me than to sit across from a patient and look at them and know what they have and give them the name of it. And in your mind, you're saying, I don't have much for you. It's frustrating, as it's not the reason we got into medicine. Now, if you have a patient like this, who's your last patient of the day at 4:30, it's no longer a drain to say, oh my gosh, that's widespread rash, it's atopic dermatitis, last patient of the day. And so now it's kind of like, let's get in there, because I'm excited, because I know that I can give them something that's likely going to change their lives, and so it makes it fun with all these new novel topicals and these systemics. What would have been, would you have had a different presentation or things you would have wanted to ask or look at in a different way?
No, I agree with you 100%. I took one look at these pictures and I was thinking systemic all the way, either a biologic like Dupi, Tralo, or Lebri, or an oral JAK inhibitor. That's definitely what I would have done too. So excited that we're here now. I think if steroid phobia had to reach a fever pitch at any moment in history, this is a good time for it, because if it had happened 10 years ago, it would have been a real bummer. But now we can prescribe really amazing regimens that are completely steroid-free, that make us happy because we're making our patients happy, and we're giving them a treatment plan that they appreciate and that they can adhere to, and they like it.
I know. And where these new novel topical creams fit in so nicely with our systemic therapies is everyone, even if they have a beautiful response and the majority of their rash is cleared and their itch is controlled and their life is improved, they all want to have something at home that they can have to treat a hot spot or to treat a mild flare or one stubborn area. So it's nice to be able to talk to them about this kind of cornucopia of non-steroidal options that we have out now. We no longer have to say, yeah, let me give you a 45-gram tube of triamcinolone to use only as needed. Now all these topicals that are out now, these novel ones that we've been talking about in all these episodes, give us the ability to kind of say, look, we put you on systemics to keep you off of so much steroids. Why don't we also continue to maintain this theme and this regiment with putting you on some of the new novel topicals that are non-steroidal also. And most patients are very happy to see that happen as well.
And a happy patient makes a happy provider, that's for sure.
That's right. Well, thanks again. Episode 3 is in the books, and we have had such a good time. Stay with us for the next episode 4 coming up soon.